Hi friends, good morning. In the yesterday's class, we discussed about sulfonamides, and the entire pharmacology of sulfonamides was completed in the yesterday's class only. And sulfonamides, as we made it clear yesterday only, they are not the drugs of much clinical significance because of two reasons. Number one, emergence of antimicrobial resistance among wide range of microorganisms. Number two, reason number two for the lesser popularity of sulfonamides is the advent or entry of some other potent drugs or promising drugs for the treatment of microbial infections. So due to these two reasons, the sulfonamides are not used alone, or they are used very rarely in the clinical practice. So in the today's class, let us try to go for one more class of agents called trimethoprim. This trimethoprim is another important class, but however, even this class is also not so much used in the clinical practice, especially alone. Why? Because bacteria will rapidly develop resistance to this class of agent we are going to discuss today. Okay, what is the agent we are going to discuss? See this is trimethoprim. We want to concentrate on today's class. Okay, we have seen the structure now. Okay, this trimethoprim na, I want to recall yesterday's class we have discussed about structure of folic acid. Is it not? Folic acid is basically made up of three components. Na? The first component, fragment A, I told you, I think you remember, fragment A is pteridine, and fragment B is PABA, para-aminobenzoic acid, and third fragment is glutamic acid. Is it not? So now you can see, you can have an observation here, pteridine and the trimethoprim. Both of them have got structural similarity. They have got a pteridine moiety basically in their structure, right? So means what? Sulfonamides are structural analogues of PABA, and trimethoprim is a structural analog of pteridine. Okay, so because of this, the trimethoprim is intervening with the function of DHFR enzyme. What is DHFR enzyme? Yesterday I told you DHFR enzyme is responsible for conversion of inactive form of folic acid into active form. That is, DHFR is converted to THFR. Dihydrofolic acid is converted into tetrahydrofolic acid in the presence of the DHFR enzyme. Okay, so this DHFR enzyme function is inhibited by trimethoprim. Similarly, I will show you one more structure, friends. This is pyrimethamine. Pyrimethamine is also having the pteridine moiety in its structure, you can see. And this pyrimethamine is effectively inhibiting DHFR enzyme of malarial parasite. So this drug is used for treatment of malarial infection. Okay, so trimethoprim is having affinity for DHFR of bacteria. It is used as antibacterial agent, whereas this pyrimethamine has got affinity for DHFR of the malarial parasite, so it is used as a anti-malarial agent. One more drug is there. You can see it has got even more similarity or resemblance with that of the pteridine moiety. You can see this. This is fourth molecule I wanted to present before you. This is methotrexate. Methotrexate has got higher affinity, much higher affinity to human dihydrofolic acid reductase enzyme. Okay, so human DHFR enzyme, if it is inhibiting, in which condition it could be useful? All of you know, it is used for treatment of cancer. Okay, so one which is having higher affinity for DHFR of bacteria is antibacterial. The other which is having higher affinity to malarial parasite, it is anti-malarial agent, that is pyrimethamine. Last one is methotrexate, having high affinity for DHFR enzyme of human beings. So this has got anti-cancer property. So there are three agents, popular agents, which are acting on same enzyme, but affinity varies. Okay, so with that, let us try to go for today's discussion. What is today's discussion? You can see the title, Cotrimoxazole. Okay, this cotrimoxazole is WHO approved fixed dose combination. What combination? Here you can see 1:5 ratio of trimethoprim and sulfamethoxazole. Okay, 1:5 combination of trimethoprim and sulfamethoxazole. So trimethoprim, just now I told you. You can ask me why the trimethoprim alone can be used for treatment of bacterial infection. No, it cannot be used. Why? Because I have told you bacteria will rapidly develop resistance to trimethoprim when it is used alone. And same story for sulfamethoxazole. When it is alone, used alone, bacteria can develop resistance to sulfamethoxazole. That's why we can use it together so that the chances of resistance will be reduced. Okay, right. Now what is this 1:5 combination of trimethoprim and sulfamethoxazole? Is it not? In pediatric conditions, you can see what is the dose. 40 mg of trimethoprim and 200 mg of sulfamethoxazole is used. Okay, and in children cases, children means 12 to 18 years, there 80 mg of trimethoprim is combined with 40 mg of sulfamethoxazole. Whereas for adults above the age of 18, trimethoprim is used at the dose of 160 mg and sulfamethoxazole is used at 800 mg, and this combination is that is 160 is to 800 of trimethoprim and sulfamethoxazole combination is known as double strength combination. It is used for treatment of some infections in adult cases. Understanding it? Or otherwise, I would like to give you one more posological formula. That is, this combination can be used in case of children having variation in the too much variation in the body weight. In such conditions, you can manage like this: 6 mg of trimethoprim and 30 mg of sulfamethoxazole per kg body weight. Like that, you can calculate. So, supposing if a child is having body weight of 40, then accordingly you should calculate, multiply 6 into 40 and 30 into 40. Like that, you should calculate. Okay. So, this is how it is used, but in all cases, you can see the trimethoprim and sulfamethoxazole are consistently used in 1:5 ratio. Okay. Right. Now, let us see why this is called as cotrimoxazole. Okay. Why it is called as cotrimoxazole? Very simple. Co means jointly. Jointly or together. We say co-education. Co-education means girls and boys together. Okay. Like that. Co means jointly or together. Tri stands for trimethoprim. Tri indicates trimethoprim, and moxazole is the suffix of sulfamethoxazole. You see, moxazole indicates about sulfamethoxazole. So combination of cotrimoxazole indicates it is combination of trimethoprim and sulfamethoxazole. Is it not? That is the rationale behind the name cotrimoxazole. Okay, right. Now let us try to concentrate on most important aspect, that is mechanism of action of the cotrimoxazole. Friends, you see here the mechanism of action. Due to structural similarity, already we have made it clear, structural similarity with PABA, sulfonamides competes with and also blocks the synthesis of dihydrofolic acid. Okay, why? Because they have got structural similarity. Yesterday only we made it clear. Now let us come to today's compound, that is trimethoprim. Due to structural similarity with the pteridine ring, you see this, it has got similarity with the first A fragment of folic acid. Okay, so trimethoprim, because of the structural similarity, will be able to inhibit the DHFR enzyme from producing active form of THF, active form of folic acid, that is called THF, that is tetrahydrofolic acid. Thus the two sequential steps of folic acid synthesis and activation is blocked, leading to bactericidal action. Both drugs alone are bacteriostatic, but in combination they are used as bactericidal agents. Okay, same thing can be even represented schematically. You can just concentrate here. I will just show you. The first is pteridine, first A fragment, and it combines with PABA, and it leads to production of what? It leads to production of dihydroteroic acid. Is it not? So this is dihydroteroic acid synthetase, or it is also known as folic acid synthetase enzyme. Now here only this is the first step where sulfonamides are blocking, intervening into the biosynthetic pathway. Okay, how? Because of structural similarity with the PABA. Okay, sulfonamides will block this enzyme. This is first step. Okay, later if it is not blocked, then what happens? It will combine with glutamic acid. Finally it forms dihydrofolic acid. This dihydrofolic acid, listen to me, will be converted into tetrahydrofolic acid in the presence of what enzyme? DHFR, dihydrofolic acid reductase enzyme. R stands for reductase enzyme. Okay, because of structural similarity of pteridine of this moiety, this trimethoprim will block the addition of two hydrogen atoms by this DHFR enzyme. Thus, there is no production of THF, that is tetrahydrofolic acid, is not produced, right? So then what happens? When the active form of folic acid is not available, it cannot contribute to DNA or RNA synthesis. Thus, cell growth and multiplication is inhibited. So, it is very clear that first step is inhibited by sulfamethoxazole and second step is inhibited by trimethoprim. That is, these two combinations are offering double check to the same metabolic pathway. Okay. So, now let us try to see what are the advantages of combining the sulfamethoxazole with trimethoprim. Why we have to combine? What is the advantage? Okay, let us try to concentrate now. The first thing is both keeps double check to the same metabolic pathway, is it not? That is the first advantage. Okay, then second advantage, I will tell you, all the remaining advantages are related to first advantage only, right? Both are bacteriostatic individually, but become bactericidal in combination. When they are combined, the combination becomes bactericidal. Okay, next, when they are used in combination, scope for development of resistance is also reduced. Okay, when bacteria are given only one drug, they may bypass one of the step and they may seek alternative and escape from the actions of one drug. But when two drugs are used at a time, bacteria will often fail to develop resistance mechanism. Okay, then next one is spectrum. So when they are used in combination, even their spectrum is also gets widened. That is another advantage. Next one is due to synergism, because they are working synergistically, right? What happens when they are working in synergism, their doses of both the individual drugs will be reduced. Supposing doses has to be taken, they will be reduced because they are working synergistically. Okay, so when their doses are reduced, automatically their corresponding adverse effects are also reduced. So these are the advantages of combining. Somebody may ask you why both drugs are combined. So you should justify these are the 5 reasons. Double check on same metabolic pathway, bacteriostatic agents becomes bactericidal in combination, then development of resistance scope is less, chances are less, then spectrum is also getting widened, and due to synergism, doses of individual drugs are reduced, thus their adverse effects are also reduced, is it not? So this is the action and this is the advantage. Okay, then next let us try to see why. Okay, why trimethoprim is combined with sulfamethoxazole only? Why can't it be combined with any other sulfa drug, like sulfadoxine is there, sulfa-L is there, and sulfasalazine is there, or sulfanilamide is there? Why it is not combined with other sulfa drugs? Let us see what is the reason for that. Because both of them have got same pharmacokinetic properties, means almost similar pharmacokinetic properties are there. Say number one, both of them are almost completely absorbed from GIT. So this is one similarity. Second one, both of them are well distributed. They have got good volume of distribution in the body. They acquire high concentrations in nude corner of our body, like they are attaining high concentrations in cerebrospinal fluid. They also attain high concentration in the lungs also, and kidney, and even they will appear in prostatic and vaginal fluids also. So means they have got high penetration power. Both are having equal distribution capacity. Okay, then another thing is the biological half-life of streptomycin is around 10 to 11 hours, whereas half-life of trimethoprim is 11 hours. Means even their biological half-life is also same. So means because of when all these things are similar, that forms a rationale for this combination. So that's why sulfamethoxazole is combined with trimethoprim. This is the reason. Then the next question is, why sulfamethoxazole and trimethoprim are used in 1:5 ratio? Means trimethoprim 1 portion and 5 portions of sulfamethoxazole. Why? Why not any other ratio? Because in studies or in vitro studies, it is found, right, in vivo as well as in vitro studies, it is found that to produce bactericidal or synergetic action, the optimum plasma concentration required is 1:20. Understood, na? So 1 portion of trimethoprim should be there and 20 portions of the sulfamethoxazole should be there. And this is attainable when you give 1:5 ratio orally.
When you give 1:5 ratio orally, after absorption, trimethoprim is little more widely distributed. So that's why they will finally attain 1:20 concentration in the plasma. That's what is the required or optimum concentration to produce maximum bactericidal action. Okay, so that's why they are used in 1:5 ratio. Okay, now let us see what are the adverse effects produced by sulfamethoxazole, this combination. What is the adverse effect produced? What adverse effects are produced? Number one, this combination produces, as usual, allergic reactions like skin rashes and GI disturbances and glossitis, etc. Then second thing is, this drug, this combination is having possibility of reducing folate availability in the body. So folic acid deficiency leads to megaloblastic anemia. You know what is megaloblastic anemia, and this side effect can be prevented by supplementing it with folic acid tablets or folic acid preparations. Okay, next, another thing is, people with or patients with the glucose 6 phosphate dehydrogenase deficiency will exhibit blood dyscreasis problem or hematological reaction with this cotrimoxazole combination. Right, this is characterized by reduced RBC count, anemia, reduced acidophil neutrophil count. Okay, then that is called granulocytopenia, then thrombocytopenia, reduced platelet count. Okay, now let us see what is the spectra of this combination. It is now effective on many varieties of streptococci and few varieties of staphylococci and some meningococci and also corneobacterium, diphtheria, and it is also effective on enterobacteriaceae, E. coli, Shigella, Salmonella, Klebsiella and Proteus. Okay, then it is also effective on Haemophilus ducreyi organism which produces cancroid, and it is also effective on protozoal organism called Pneumocystis carini, that is the organism. Okay, right, now on this basis let us try to see what are the therapeutic uses of this class of agents. Okay, so now what therapeutic uses are there? Number one is, they are used for treatment of acute uncomplicated urinary tract infection. Regularly it is used. We have seen, even I have seen personally that doctors are using it for treatment of acute uncomplicated urinary tract infection. Okay, then next one is chronic recurrent urinary tract infection, and here in acute cases it is used regularly, means 2 times a day, 12 hoursly once. It is used for 7 to 10 days, whereas for treatment of chronic cases it is used thrice weekly. Then next, it is also used for treatment of bacterial prostatitis. Okay, then next it is used for treatment of uncomplicated respiratory tract infections, and as I told, some of the unabsorbable agents or some this combination bacillary dysentery and also enteritis also it is used. Then next one, it is used as an alternative to treat typhoid. It is not a first choice drug. You know very well that fluoroquinolones are used, or ceftriaxone is used, that is third generation cephalosporins can be preferred, but anyway this can also be used as an alternative. Next, it is also used for treatment of pneumocystis pneumonia, and last one, it is used for treatment of cancroid. Of course, for cancroid also this is not preferred drug. Actually, azithromycin is first choice drug, but it can also be used as an alternative for treatment of cancroid. Okay, so this is about the cotrimoxazole, that is combination of trimethoprim and sulfamethoxazole in 1:5 ratio. Thank you.